Welcome, everybody. Hello, everybody. Welcome to Tuesday afternoon, morning, evening, wherever you are, edition of CPS Video Morning Report. So welcome. Great to see everybody here. I see a lot of familiar faces, a lot of people with their videos turned on. Hey, Scott, Aaron already, Sudarshan, Varsha, Hans, Kaleem, Nitya, Zachary, how are you? Lucas, I see your picture. But yeah, I hope everybody is well. We have case presenter Sudarshan today. And also Varsha will be doing teaching points and scribing Aaron. And before we get underway, I want to introduce my fabulous, the one and only, my brother, Kirtan. How are you? You want to
Hi,
introduce?
friends. Yes, sure. Hi, friends. Thank you so much for joining on this Tuesday VMR. I always say, right, that the way I start my off weeks is by discussing with Dr. Singh. So because as a hospitalist, you have like 7 days on, 7 days off. And the way the schedule works is that Tuesday is the first day off after Monday. So it's the best way to start my off week by discussing with Dr. Singh. And I'm even more excited because Dr. Singh has been working in ICU kind of environment for past 1 week. And whenever you're in ICU, what happens is that your brain becomes electric fast because not only you are primed to think about the diagnostics of a case, but you also have to manage the patients in a very random and at the same time very organized way, right? Like randomness and organization has to go hand in hand to make things happen. So I'm glad that Dr. Singh is here with us, and I'm sure that his skills will help us today in diagnosing the case. Dr. Singh, do you want to tell us how has been your journey in ICU?
Oh yeah, I've been in ICU step down. I was just talking to Keith, yeah, usually we do medical floors and we have patients and they're stable. They can become unstable, but when you're on the receiving end of having very unstable patients with electrolyte issues, oxygenation issues, blood pressure issues, like it's very can be very nerve-wracking because when you're in the ICU step down, they either go to ICU or they go to the floor when they're stable. I also have what I actually am glad to introduce. I have a few medical students that are currently rotating with at my institution in medicine. So Jack here is here, Connor, who else? Joy is here. Am I missing? Oh, one of my residents is here, Prithvi, who presented a case before. So I'm glad to see a lot of people that are learning with me are here. So Kirtan, you have to do a lot of good teaching because you have a great audience today.
Yes, I'm super excited, and then we can pass mic to Sud. Hi, Sud. How are things going with you today?
I'm good. Thank you for having me. Feels like a deja vu. My first case presentation was with Dr. Singh, and here I am again. Um, Also nervous to know that there's so many people in the audience that you already know. But I'm excited to present the case to you guys.
Of course. Thank you so much for joining us, Sud. And then, hi, Aaron. Aaron is helping with the scribing today.
Hey everyone, excited for Sudarshan's case today and learning from Dr. Ravi and Kirtan.
Thanks, Aaron. Hi, Varsha. How are things with you?
Hello everyone, happy Tuesday. I'm super excited for Sudarshan's case and the next hour of learning that's coming our way.
Perfect. Thank you so much, Varsha, for helping with the teaching points today. All right, well, Sud, let's get started whenever you are ready.
Awesome. So for the first report, we have a 60-year-old woman who lives in a group home that presents to the ED with right-sided chest pain.
Perfect. Dr. Singh, you go first.
Interesting. Yeah, we usually talk about left-sided chest pain, but right side, I like this. Like right-sided chest pain, I haven't thought about in a while. But like I'm going to be directing. I have my students here. I'm going to meet them at 1 p.m. to discuss about connective tissue disorders. But what we usually do here, we start kind of exploring this space of the patient and also the complaint that the patient's coming with. So, the age range 60, prime for certain conditions. And when I hear chest pain reflexively, I'm going to think about coronary artery disease and ACS. But this is kind of odd because textbook or foundational medicine will teach us left-sided chest pain, and then embryologically the nerves share roots with the left arm, the sensory nerves, and maybe the left jaw and the left neck and so on, the radiation. So the character of the pain, the radiation, exacerbating factors, and so on. So if I was seeing this patient in the emergency room, this hypothetical patient, which has been seen by Sudarshan, I would start asking these questions to probe further. Now, right-sided is a very atypical sort of manifestation. You still have to think about ACS because ACS can manifest very atypically in women. So at this point, chest pain is one of those ones where I'm going to think front and center ACS, but also start to think about a differential diagnosis. I'm going to turn the mic over to Kirtan to then explore this space further.
No, excellent analysis, Dr. Singh, right? That we often talk about this in the world of abdominal pain as well, that in our mind we have broad localizations, that right upper quadrant, right lower quadrant, left upper quadrant, epigastric, suprapubic, right? But then as you see more and more patients, you realize that body doesn't follow those quadrants rule. That quadrant is just for our simplification. And the reason is simple, right? That every patient is different, and the way they perceive the discomfort, the way they perceive the pain is also different. Oftentimes what happens is that I myself, let's say sometimes I'm sleeping the wrong way, and when I wake up in the morning, I would be like, I'm having left chest discomfort. But then after a while, I will be like, wait, was it left? And then I will ask myself that, okay, what is left? What is right? I will look at my fingers, how I write, and I'm like, okay, I'm left-handed. But wait, actually it was on the right side. So you could see that how simple things like this, that even left and right, sometimes people can confuse. Like people really don't know whether it was left or right. They can't say with certainty, right? And as you could imagine, that our body is like this big, right? Like the cavity is not that big. So you could imagine that how pathology in one part of the chest can still end up causing some pain in the other part of the chest. And hence the part which Dr. Singh highlighted, although right side seems atypical as per the textbook, but ACS is still the forefront, right? And ACS is just an example, but what does it tell us, right? It tells us that sometimes history is not straightforward, and you can try your best to clarify the symptoms, but even after that you may not make much progress. And that's why you go with the big guiding principles, that you know that something is wrong with the chest, and then you try to evaluate based on the past medical history, that what are the risk factors, based on the physical examination, based on the imaging, and then only you can make the progress, right? And in this case, the first thing we will do from Sudarshan is, once we get the HPI, is that what does patient mean when they say chest pain, right? Sometimes it is possible that patient actually has dyspnea or short of breath. Maybe they are not able to converse properly. Maybe they walk few steps and then they are out of their breath, right? Sometimes it is possible that patient just feels that once in a while their heart starts racing, and that is why they are feeling this sensation of chest pain, right? So we need to know that what is chest pain actually, right? And then once you have figured it out that what is chest pain, then you can play around. And how Dr. Singh was saying, like anatomically speaking, right? That you think about the vessels, and hence we think about coronaries, aorta, your pulmonary arteries. You think about the layers of the heart and layers of the thorax. So pleura, pericardium, mediastinum, right? And then you could imagine that how irritation or pathology of any of those things, vessels, pleura, pericardium, can end up causing chest pain. And similarly, things from beneath the body, which means that something is wrong with your abdominal cavity, and it is kind of irritating your pleural lining and causing the sensation of chest pain, right? And similarly, think about it that our thorax is a cage, right? We often focus more on the anterior part of the cage. That is where the pleura, pericardium, ACS, everything is located. But we forget about the posterior part of the cage, right? That is where all the retroperitoneal, posterior mediastinal structures and the spine is situated, right? So all this is to say that you need to get a very good history, and then you need to operate based on certain guiding principles, imaging and labs, to make sense of what is this chest pain, right? Dr. Singh, anything to add?
Yeah, I just love that you're bringing in the importance of anatomy, and just you need a very laser focused review of systems, which will help. Like you say, then the patient may switch to, oh, there's a lot of shortness of breath. Then you have to think differently, or there's dizziness. So a lot of that review of systems will be really helpful in trying to narrow your focus to maybe a particular condition. But yeah, let's send the mic back to Sudarshan for the next eloquent.
Awesome discussion. Speaking of review of systems, so she endorses having a right-sided chest and abdominal pain. She's had nausea and vomiting and a cough for several days. She doesn't really quantify. She denied any shortness of breath, fever, chills, or trauma, and this is all we could get out of her. She is not a reliable historian, and so the HPI review systems was very limited. So her past medical history, she has paranoid schizophrenia, intellectual disability, major depressive disorder, hyperlipidemia. We're not able to obtain any family history. Social history, she lives in a group home. She denies any alcohol or substance use, has never smoked. Um, and for her medications, she was on aripiprazole, a long-acting injectable given to her monthly, fluoxetine, benztropine, atorvastatin, and no known drug allergies. Um, Physical exam. She's in no acute distress. CVS, there's a murmur, best heard at the right upper sternal border. Um, uh, Respiratory system, decreased breath sounds on the right. Per abdomen, soft, mildly tender to palpation on the right side, non-distended. Skin is warm, good turgor. Neurologic exam, there's no focal neurological deficits. Psych exam, poor insight into her clinical condition. And I'll stop there.
Perfect. Thank you so much for giving us this piece of data. So, friends, as you're discussing in first episode, right, sometimes it's just challenging to figure out that what is the actual symptom we are trying to figure out. Like we thought there is chest pain, but then we were like, okay, let's be broad and let's see what else it could be. And now seems like that there is some degree of abdominal pain, some non-specific symptoms of nausea, vomiting, cough, and as they always say, right, that the history is as good as the mental state of the patient, right? If your patient is altered for XYZ reasons, you're not going to get a good history, right? And this is the similar situation we are in, right? That given the patient's psychiatric history and looks like the patient doesn't have clear insights, we don't know what is going on. And if patients are living with their family members, you can get collateral history. But as the people get older and older, and as we go into the geriatrics world, oftentimes, unfortunately, this is what happens, that you are living in the nursing home, you're living in the like group facilities like this patient was in, and there is not enough resources available at those places to cater to the needs. So who will you talk to, right? Like for example, Sudarshan told us that this patient has symptoms for few days. Now, those few days can be 1 week to 3 weeks to 1 month. We have no idea, right? So, and unfortunately, there is no even way to clarify, because what will you do, right? So, all we can say to the best of our abilities is that likely this is subacute to chronic problem, probably not acute. And the reason why maybe the patient came is because the discomfort in their abdomen was too much, right? Looks like the vitally patient is doing fine. So it's not like that they were in shock or they were completely confused, unresponsive. That is the reason why they are here, right? So the only perceived way they might have come here is because of the discomfort, which is now getting to the point that they can't function properly, right? Did we find anything more focal in examination that we can direct our attention to? So not really. All we saw is that there is some murmur there. But as always, that when you see your examination findings, you need to validate it based on the imaging studies, based on the more objective evidence. And you want to see that is it new or not, right? If this person has like some murmur for 5 years and now they are coming with something else, then very likely the murmur is not related, right? So like it's very hard for me to make progress in this case, because all we know is that there is like some chest pain, abdominal pain, right? And no focal signs and symptoms, no real clinical context which could make sense. So in such scenarios, what you should do is that you should gather as much data as possible, right? So get the basic labs, see if your troponin is leaking, if your BNP is high, right? If your electrolytes are doing okay or not, how are your kidneys, how is your hematological system, how is your liver doing, right? And that could shed a light on what might be going on, right? For example, if this person's like AST is 5,000, then things might start to make sense that, okay, maybe it is the hepatic injury, hepatic inflammation, which is causing nausea, vomiting. And now patient also has some degree of chest pain, telling us that the pathology is worsening or extending beyond the abdomen, right? Similarly, if we see that patients like creatinine is 10, then we might make sense that, okay, maybe patient is going into that uremic phase. Maybe the patient has too many toxins building up in the system, and that is the reason why they are presenting in this way, right? So all this to say is that you need some degree of basic data coming your way to make progress, right? And of course, like whenever such people come to your hospital who have no clear way of giving you the history and no way for you to find anything on examination, you have to get the cross-sectional imaging, right? So this is one of those scenarios where like x-rays may not help you. Like x-rays are more helpful like when you know what you are looking for and you have time crunch, right? In this case, likely we do not have time crunch because patient has been suffering from this for at least few weeks. So getting CT scan would cost you maybe 10 or 15 more minutes than an X-ray, which is reasonable, right? So I think this person would benefit from CT angiogram of chest, abdomen, and pelvis, so that we can look at the blood vessels everywhere. We can look at the cavities, that what is going on, and that could give us clue as to how we make sense of this, right? Dr. Singh, any ideas coming to your mind?
I think this is getting very interesting. I think, yeah, first front and center, because with this abdominal tenderness, it still can be ACS. So we have to be careful that we don't go or totally pivot to another workup, which could be GI, and ignore again ACS, because ACS can be very atypical again. And I've had patients or presentations have been described below the belt sometimes. Epigastric pain can be ACS. So it's imperative to get, like you said, get the EKG, get the troponins. You want to run on two tracks. One is trying to diagnose what's happening, and the second is trying to investigate or ordering the investigations to support or refute your hypothesis. So say while you're working up the patient, you get the EKG troponin, it comes back, it's negative, you can then pivot away from a thought of maybe ACS and then look into maybe abdominal issues. So it's interesting. I did, reflecting on experience. So experiential learning is very important. The reason why, as a medical student or as a resident, you work in the hospital, handle many cases, is to build up a repertoire of experience or cases that you see, and then you can reflect back on when you're seeing new patients. I had a patient that came with chest pain, and I was like, okay, this is probably chest pain due to ACS, or it could be something in the lungs, things like that, sinusitis. But then what was odd, the labs, we haven't gotten the labs, but like you mentioned, the AST, ALT were mildly disturbed. The Billy was a little up. ALP was high. And I go back and then I start pushing on the abdomen, and she had Murphy sign. I was like, wait, you said you had chest pain. She said, yeah, but this really hurts now. So she didn't, present with abdominal pain. She said, my chest hurts. So it can happen like that. And you have to have a very broad approach. That's why having a differential diagnosis is very important, because that patient, sometimes I think back, could have easily just transitioned to a chest pain, rule out MI workup, and we could have missed a cholecystitis. This patient went for cholecystectomy the next day. So that was a great learning case for me, because textbook wise, you come with right upper quadrant pain, Murphy sign, lab abnormalities, and that's acute cholecystitis. So I would start probing the right side of the abdomen, like you said, what's on that right side, reflect back on your anatomy, liver, the hepatic flexure, maybe part of the stomach, and other organs, kidneys a little lower, pancreas may also be in that side as well. So any of those organs are fair game for any sort of pathology as well. So imaging, yeah, imaging will be crucial while you have some of the lab workup cooking, like the CBC chemistry, troponin, and EKG. Anything else before we send the mic back?
No, I think that's what we can do best from our side, and maybe Sud can tell us if they got a chance to talk to the patient's facility, right? Like if the facility can tell us that what happened, right? Yeah.
Yeah, just one thing I forgot, the medications. We sometimes just look over medication, but I remember fluoxetine and eproprazole can have nausea, vomiting, gastrointestinal complaints. I doubt this is the cause, but always investigate the medications. I really like just second point, facilities, when they send us patients, is crucial to get baseline, how is the patient, all that information, because sometimes the patients come and we have no backstory, how they were doing the last few days. We'll send the mic back to Sudarshan.
Awesome discussion. This is kind of the same thing that we were thinking about, just going ahead with imaging. We just did not get an X-ray. Just went ahead with a CT, but before that, the vitals when the patient came in were pretty unremarkable, except for a blood pressure of 133/83. That's not really remarkable. And so for her labs, her WBC count was 6.5, hemoglobin of 12.7, platelets of 439. The white cells had a neutrophilic predominance of 78 with relative lymphopenia. We unfortunately did not have a baseline. A BMP was also unremarkable. A creat of 0.8, glucose of 108, and normal lights. A quark panel showed a PT of 13.4, an INR of 1.16, a PTT of 30.8, an albumin of 3.9, and LFTs were within normal limits. A UA was done, which showed trace protein and ketones, but was otherwise unremarkable. And before I go to the imaging, an EKG was done that was normal as well. And we did centropes, which was actually mildly elevated, I think at around 45. But I will let you know that the delta trope was, again, non-significant. And so for imaging, a CT head was done, which showed no acute intracranial hemorrhage or past lesion. A CTP was done, showed no no PE, and obstruction was seen at the right main stem bronchus with near complete atelectasis of the right lung and a moderate large right pleural effusion. Stop here.
Okay, so a lot of things to break down, but I'll tackle the CBC. Chemistry is also doesn't have much. So there's really nothing red there, right? That we can really pin our thoughts on, or something that can actually support our hypothesis there. The only thing I'll comment about the white cell count, there is a burgeoning neutrophilia that Sudarshan just mentioned, right? What does that mean when you're looking at the fine granular details? This could be a burgeoning leukocytosis in evolution. So, as you know, we are all on a journey. Similarly, patients are all on a journey, and pathology is on a journey too. So today, the white count is 6.5. The neutrophils are increasing, and they also mentioned lymphopenia. So at the expense of the lymphocytes, the neutrophils are increasing, and eventually the struggling bone marrow may, or the demargination that happens, may culminate in tomorrow a leukocytosis 12, 13, and so on. So, that's how I kind of look at it. I'm still kind of wondering if there's infection. Sometimes you don't have the signals. Every phenotype is different. Everybody will manifest with infections differently. Some people may have an immunocompromised state, so they won't have the signals of fever, white count, tachycardia, tachypnea, and so on. So you have to be really careful with those patients and have a low threshold for possible evolution of sepsis. So here it's kind of interesting. I got some information from the CAT scan, but we have to start thinking about maybe an infectious cause with this patient. The signals aren't there. We don't have a fever. We don't have a burgeoning white count. The white count may be trying to mount a response. The chemistries really are nothing. We wanted the Kirtan, you talked about liver enzymes. If the liver is involved in this process, the coag is fine, UA is fine. But there's this interesting imaging. And I think early on, the chat was thinking about what else can you have on the right side, which is in this CT. And I'll let Kirtan discuss this. Over to you, Kirtan.
Yeah, no, thank you so much, Dr. Singh, for highlighting the evolving process of the labs, right? That we just get one piece of data when we are in the VMR, but then you don't know how the WBC will be looking tomorrow, right? And as like I always say this when I'm presenting the cases and when I'm with my residents, right? That what are the basic tests which you need in any person, right? And even more so in this particular person, given the fact that the history is like we don't get much out of the patient, we don't know what is really relevant or not, is the what we call as the standard set of labs, which includes, apart from what Sud told us, you should always get HIV, you should get hepatitis B and C, syphilis, TSH, vitamin B12, ferritin, and drug screen. Like these are the tests which I obtained in every single patient. Like other week, I had a 97-year-old patient who just came for like some elective G-tube placement. I went ahead and got HIV, Hep B, C, syphilis, TSH, B12, ferritin, toxin. Always. This should be your ABCD. You should always get it. And you would be surprised how many times you would find random things like, oh, someone had Hep C positive for like 10 years. No one checked. And then they realize that, well, this person also has neuropathy, which we don't know what is going on. And now it will be like, oh, it was HCV causing neuropathy, right? So all this is to say that the basic labs are basic labs. You should always get it. And why it is even more relevant in our case is because like Dr. Singh was highlighting the CBC with diff, right? And Sudarshan told us that maybe there is some degree of lymphopenia. Now, again, you should not look too much into one set of labs, but even if there was no lymphopenia, you should go ahead and get HIV, right? So in this person, we should get those labs, see if we make some progress from there or not, right? Even if we can't make any progress, that's fine. Those are the basic labs, we should get it. The other important thing for this patient is that whenever you have a patient who has like some degree of psychiatric history and you really don't know their nutritional status, you really don't know how well they are taken care of, even before you send the levels, like in this person, you can check like vitamin B1 if you need, but there is very low threshold to just give IV thiamine. Like there is no harm in giving IV thiamine, but the yield is too much. Like if this patient is even slightly altered for any reason, you give IV thiamine within 24 to 48 hours, they will perk up and you will get more crucial data, which might make you help progress. Like maybe the final diagnosis is not Wernicke's, but the patient will be more like alert in 24 hours and will be able to tell you that, oh, you know what, doc, I have been having bloody stools. And then this abdominal pain started. So you will get more piece of data, which you have no way of getting until the patient comes out of their hibernation, right? So in this patient, that is another thing I will do. I will get those basic labs done, and then I will give IV thiamine, right? And now coming to the imaging findings, very peculiar, and I will ask Dr. Singh also what he makes of this, right? That first and foremost, you need to know that when you have this large unilateral pleural effusion, the basic things that all the transudative causes that you think about, like maybe heart pathologies, maybe liver pathologies, maybe the kidney pathologies, they can still happen. But given that we don't have any real risk factor going on and the clinical examination is not concerning, albumin is looking okay, UA is looking fine, the foremost consideration has to be that this is exudative effusion unless proven otherwise, right? So for simplistically speaking, if you now start looking at the causes of exudative effusion, what is the algorithm you want to follow, right? So first and foremost, you want to rule out any catastrophic vascular pathology, right? People can have exudative effusions from pulmonary embolism. Sud told us there is no pulmonary embolism. So that part is gone. And they did the CTPE. So CTPE usually looks at all the vessels, not just pulmonary arteries. So even if aorta was culprit in some way, sometimes people can have aortic dissection, which is chronic and which can cause effusions because of the retrograde spread. We would have seen it. So this person does not even have aortic pathology. So we can breathe easily that this is likely not a vascular pathology. Then the remaining two big buckets, apart from some rare causes, are like infections and neoplasms, right? Could this be an infectious effusion, like parapneumonic effusion? Now, in general, if you have parapneumonic effusion, you tend to see something in the lung parenchyma as well, right? That it would be pretty unusual for, let's say, streptococcus pneumonia, a classic bug, to cause a massive effusion without leaving any trace on the parenchyma at all, right? In our case, all we know is patient has some atelectasis, but no real consolidation, and patient does not have like what other signs and symptoms you might expect from a pneumonia, right? Like fevers, chills, leukocytosis. Now, not to say that you need to have them all the time, depends on your immune status, depend on which bug you're talking about. But all this to say that the typical infections are a little bit lower on the differentials, right? You can always have rare indolent granulomatous infections which can just reside in the pleura. The classic example is, think about tuberculosis, right? That people can have TB pleurisy, which means the TB is residing only in the pleura. It is not in your airways, not in your parenchyma, not in your lymph nodes, not anywhere else, which means there is no way to detect it. And the only way to detect it is in the pleura, right? So similarly, there are unique organisms apart from TB, kind of cousins of TB and in the family of TB-like organisms which can do that. But that's the best guess. But then again, we don't have the other classic symptoms which you might expect from such kind of people, right? So we went from vascular pathologies to exudative infectious causes, and then you are left with the neoplastic causes, right? And in the neoplasm, the big picture is that, is the neoplasm originating from the thorax itself? Like, is this a lung cancer? Is this a lymphoma? Is this a mesothelioma? Or did it come from somewhere else? Which means, did it come from abdomen and pelvis? Did it come from extremity? Does this person have like melanoma, right? So that is what you need to figure out. And for that, you need more imaging, right? So we got the chest imaging. Now next should be, you should get the abdomen pelvis imaging as well to see that is something wrong with the abdomen as well, or is this isolated pleural pathology, right? And Sud hasn't told us anything about the lymph node in like lymphadenopathy in the mediastinal mass. So it's pretty peculiar, right? That where is this, if there is neoplasm, where is it coming from, right? And the clue can be in what else Sud told us in terms of the airway, right? So we know that there is obstructions in the right main stem bronchus, and there are multiple causes of why there could be obstruction there. But maybe I can pass the mic to Dr. Singh that what does he make of that obstruction in right main stem bronchus and how it can relate to the effusion.
Kirtan, I have a surprise to you. So that was applause, a sound effect. Why? What's interesting, you talked about thiamine, right? And the issue of thiamine. That was my discussion on rounds this morning. That was my discussion points. So Jack Parker is my medical student here, and he was there. We talked about thiamine and refeeding syndrome. With very sick patients, you have to worry we don't feed them for like several days. And when you start feeding them, just to sort of go on a tangent, you have to think about refeeding syndrome. But you're right. We don't also identify that a large portion of our senior population is malnourished, is not eating, is chronically ill, is hypercatabolic. So thiamine deficiency does exist. And just by giving them thiamine, you actually may improve, and it's a very cheap sort of intervention, it may improve their mental status. So be on the lookout and also pay attention to refeeding syndrome. But going back to this, what's interesting, yeah, I think unilateral, plus there's this obstruction in the right mainstem bronchus. And that to me, I'm very worried about, right? So when you have a mainstem bronchus, what's nicely described is atelectasis. How do you get atelectasis? Either you have microatelectasis by consumption or destruction of the surfactant, and then ARDS culminates from that when you have destruction of the surfactant. The pancreatitis actually is a cause as well of atelectasis and the surfactant destruction. Then you also have resorptive from endobronchial lesion or compressive. Here we have two reasons for this atelectasis. One is compression from the pleural effusion. The other is an endobronchial lesion, so it limits the amount of air into the lung, and then it has no other choice but to collapse because you can't get air in there. And this, endobronchial lesion raises suspicion of some endobronchial mass, which could be cancer. It could be infection. It could be, I presented a case many years ago. I don't know, you know about this, right? Broncholiithiasis, right? So it was a case of histoplasmosis, and the lymph node surrounding the airway burrowed themselves into the airway and caused hemoptysis, and then it enters the bronchus, causes wheezing on its passage into the bronchus, and then you cough it up as a broncholith, literally a stone. So I had a patient present like that. He was coughing stones, and I'm like, how do you cough stones? And it was a great learning case for me, which I presented back I actually had my medical student presented back in 2001, 2002, somewhere around there. So yeah, I'm worried about that endobronchial lesion. Number two, we need to do a thoracentesis, get the pleural effusion, apply Light's criteria to it, and do targeted cellular testing if it is malignancy. And then if we can't get a diagnosis, do a pleural biopsy. Anything else before we send the mic back to Sudarshan?
So no, Dr. Singh, that's what I wanted to highlight, right, friends, and the way Dr. Singh highlighted two important causes of atelectasis, it also tells you how the imaging looks, right? So for example, you might have seen that when there is moderate to severe pleural effusion, oftentimes you will see the contralateral shift. So in this case, your right-sided pleural effusion, you might expect left mediastinal shift, but we did not see any shift, right? And sometimes the reason why this happens is that you have two contradictory forces, right? You have atelectasis, which is also on the right side. Now, atelectasis usually causes shifts on the ipsilateral side. So now your pleural effusion is trying to push your mediastinum to the left side, but the atelectasis, due to the endobronchial obstruction, is trying to push mediastinum towards the right side. And both these forces cancel out, and that is the reason why sometimes you don't see mediastinal shift. But why this is important to contemplate this, because it tells you that the underlying pathology may be severe enough to cause a mediastinal shift, but it is not happening because of two counterbalancing forces, right? And it also tells you the severity of all of them, right? That the atelectasis is not just trivial, because what is the most common cause of right lower lobe or any kind of lobe which is collapsing is aspiration, right? You might wonder that this person who doesn't have good insight, they are on a couple of medications, who knows what if they overdosed on some of them, and maybe their aspiration is their swallowing is not good. They aspirated some part of the food products in the right lower lobe, and maybe there is some mucus which is building up there, and all of that caused the collapse, right? Now, that is a fair hypothesis and it can happen. But what we more worry about is that none of them should explain the effusion, right? If you have foreign body stuck there, even if you have aspiration pneumonia, you should not expect moderate to large effusion, right? So that is the reason why what Dr. Singh was saying was that he's worried about a mass, right? He's worried about a malignancy. And the equation is simple. that if your lobe is collapsing, a particular bronchi, how can it collapse? Something is inside, something is in the wall, something is outside. If there was something outside the bronchi, as in a big lung mass or big lymph node which was doing this, it would have been evident on imaging. So what is remaining is something in the wall or something inside the lumen. And this is again the simple analogy. How do you diagnose colorectal cancer? Not by CT scans, but by endoscopy, right? So whenever something is in the lumen, you can see its evidence on the cross-sectional imaging, but the ideal way to evaluate that is by endoscopic evaluation, right? So this person needs the bronchoscopy. And once you do the bronchoscopy, then you can expand your differential based on what you see, right? That are you seeing a stricture? If we are seeing a mass, what kind of mass it is? Is it benign? Is it neoplastic, right? And then you can try to create the differential list as to what this could be. And similarly, you have the effusion. So you first try to understand that where is the effusion stemming from, right? So as we said that you should still get the abdomen pelvis cross-sectional imaging to see if something is wrong with your abdomen, your liver, most importantly, because that is in close proximity to your right, like your the right lower lobe of the lung, right? And then you tap the fluid as well. And once you tap the fluid, based on its fluid characteristic and based on the BAL findings, you combine those two findings and then you decide that, okay, which route I am going, right? Is this neoplastic? Is this granulomatous infection? Or is this a third, like rare bucket, which we haven't thought about yet, right? But we can't make that progress yet until we get those two data points, right? So, Dr. Singh, anything to add before we go to Sud?
Oh, just wonderful. I think, yeah, I didn't add foreign body, but that also, I guess if you aspirate, you should have a coughing reflex, right? But what if it gets stuck and just sits there and granulates into the wall of the bronchus? But yeah, great walkthrough of, I love this push and pull phenomena, they call it, right? The pleural effusion pushing and the lactasis is pulling towards, or the ipsilateral mediastinal shift. But we'll hand the mic over to Sudarshan for the next aliquot.
I love how you guys are just bouncing thoughts off of each other. This is very illuminating. So before we go to the bronchoscopy, which is done, I'll round up the imaging. We did a CT abdomen and pelvis, which showed a 6.9 centimeter peripherally calcified cystic lesion in the anterior pelvis that was most likely ovarian in origin. There's also a moderate to large stool burden throughout the colon. And so to check this out, a pelvic ultrasound was done and showed a 7.8 centimeter complex cystic right adnexal mass with solid components and minimum vascularity. So at this point, she was transferred for a bronchoscopy. And so bronchoscopy findings were the right mainstem bronchus was greater than 90% obstructed by an endobronchial lesion, and a cryotherapy debulking was performed. There's also a separate lesion noted in the right middle lobe and another endobronchial lesion in the left mainstem bronchus. The pathology findings from the biopsy taken here was that it was an adenocarcinoma with mucinous and signet ring cell features. Immunostaining was positive for CDX2, CK20, CK7, and negative for TTF1, NAPSIN, PAX8, ER, and GATA3. Not sure what that is, but and tumor markers were done as well. CA 125 was 49, AFP was 2, beta HCG was 4, CA was 6.2, CA 19.9 was 289. The immunostaining actually argued that the source was probably GI or pancreatobiliary rather than a ovarian or lung primary. I'll stop it.
Thank you so much, Sud, for giving us extensive data all the way to the end. And Dr. Singh, I forgot, is it your turn or my turn?
Oh yeah, I forgot. Well, go ahead.
Yeah,
I forgot
sure.
to.
So friends, as like if we just take a moment and reflect on what is the journey, right? Like we don't want to lose the sight of where we started, right? So seems like it was a middle-aged lady who is presenting with maybe subacute to chronic symptoms. The symptoms were non-specific, maybe some chest pain, some abdominal pain, nausea, vomiting. So we said that when things are not making sense, you really can't do much. You can rely on examination a little bit, but your examination can only get you so far. You will rely on basic labs and cross-sectional imaging, right? So that is what we did. And we find out that this person had pleural effusion and right lower lobe bronchial obstruction. And that was the reason for maybe why this person had chest pain, right? And then we figure out that, okay, if you have effusion, but your parenchyma otherwise looks okay, the likelihood of this being transudative is low because it's unilateral. The likelihood of this being classic infections is low because there's nothing in the parenchyma. So we were hoping that we will find clues in the disseminated neoplastic process or granulomatous infection based on cross-sectional imaging. So we got the CT abdomen and pelvis, and now we found that there is this multilobulated cystic lesion in the ovaries, right? Now, the thing is that since we as an internist are not much exposed to the gynecologic pathology, sometimes we don't have enough experience to figure out that, okay, is this something which can be just a benign or is this something which is pathologic, right? But the few clues helps you that whenever things are unilateral, so rather than being bilateral, and they are just too big in size. Now, I know this sounds weird that like you are just saying too big, what is too big, right? But you could imagine that every single tumor you think about, one of the key distinctions between benign and malignant is the size. Like think about pheochromocytoma, you always say that, oh, if the adrenal lesion is more than 4 centimeters, it's more likely to be malignant, right? So similarly, in this case, if you see just the sheer size kind of makes you wonder that likely this will be malignant. And then you look at the features, right? That if this was a simple cyst, it would be likely well-rounded, well encapsulated, right? But now we are saying the multiloculations, we are saying the calcifications, all of this kind of adds one point towards this being non-benign cause, right? So it makes sense that, okay, likely this person is old enough, is in the right risk factor age group to get the malignant pathology, right? But then you always do the clinicopathologic correlation, right? That you found something in the ovaries and you found multiple lesions in the endobronchial sites in the lungs. Are they related? Like the same thing in the ovary is going there as well? And then you like, based on the prior experiences you have, or you can, based on literature research, you can figure out that how does ovarian neoplasm, let's imagine that this person had ovarian adenocarcinoma. How does it metastasize, right? That does ovarian adenocarcinoma go to airways? And you will find the answer that likely it is not the most common cause. The most common malignancies which can cause endobronchial lesion are usually the benign causes, like things like hematomas, carcinoid tumors, and lung cancers. So it is very unusual for a solid tumor of ovarian origin to go into the airway but not affect the lung parenchyma, right? So that itself tells you that, wait, let's hang on a second. That are we sure this is ovarian adenocarcinoma? What if it is a different kind of malignancy which went to the ovaries and went to the airways at the same time, right? And that is where the histopathology comes into the picture, right? And in this case, looks like that Su's team did the extensive staining. And like, I don't know the relevance of all of them, but like the basic picture is that the CK20, CK7 usually hints you towards the squamous cell origin. Like if it is a squamous cell carcinoma, then usually the CKs are positive, right? Similarly, TTF1 and NAPSIN are more for lung adenocarcinoma. So if they were positive, you think about that. If it was S100, then you think about the small cell neuroendocrine pathology. So in this case, the big picture is that likely this didn't originate from the lung itself, right? So then you are left with, is it ovarian or not, or is it other organs? And that's why we did the GATA3. And if I'm not wrong, like GATA3 is of the breast cancer. So oftentimes people can have breast cancer, which can go, and you can't capture breast cancer on CAT scans, you need mammogram, right? But GATA3 is negative, which kind of argues against the breast cancer as well, right? And then what we are left is with the certain other markers, which told us that this is adenocarcinoma, right? But not lung adenocarcinoma. Then you again go to the clinical pathology correlation, that what kind of adenocarcinomas in the body are known to produce significant amount of mucin, right? So apart from the ovarian, most of the remaining mucinous tumor are from GI tract. So think about the appendiceal neoplasms, think about the gastric neoplasms, think about the pancreatic neoplasms, right? So, and then Sudarshan told us that there is a signet ring pathology as well. So again, if you think about like all the tumors which causes mucinous neoplasm but also causes signet, then you again zoom it down more to the gastric neoplasm. And gastric adenocarcinoma, as we know, has propensity to go to the ovaries as well. And there have been cases on CPCRs in the past of like what is known as like the Kuchenberg tumor, as they ask in the board exams, right? That where you have ovarian mets actually from a GI tract origin, right? So like it's important. Sometimes we think that what is the importance of knowing all the markers as an internist, and that is true that we don't need to know each and every one of them in details. But in a peculiar case like this, sometimes imaging is not enough. You need some degree of like prior baseline knowledge as to how the tumor spread, what is the normal biology of individual tumor. So in this case, it could have been easily choked on as the ovarian cancer which spread everywhere else, right? But then you ask yourself that, well, histopathology is not matching and the tumor characteristics is also not matching, right? So very sad case that how this like lady suffered from all these things. Dr. Singh, any next steps you have in mind? Any other reflections?
Oh no, you pretty much described everything. I don't think there's much else there. But the chat has been very interesting. While you were talking, I was also scanning the chat, and it was interesting. Like, when you think about what is this mucinous and then signet ring, and the way the configuration is, if you think about it in histopathology, there's mucin intracellularly within signet ring, and it displaces the nuclei, so it looks like a signet, like a ring. Whereas in mucinous, it's extracellular and it's on the outside. And you rightly said the mucinous would be more GI in this case, and the way it's spread would be peritoneal, metastatic, whereas the signet ring would be more intra within the wall or lymphatic system spread, which could be what explains going to both the ovary or the ovary region and also the lung there. But to have both of them is very confusing. And I think if you look at the markers, like you said, positive for the CDCX, those are colorectal. The other negative for primary lung, the what do you call it? NX, no, the PAX and GATA and so on. Negative for those, so negative for lung there. So this would be a colorectal GI source. And I think this is where our oncology friends would need to come in and do some fine probing to see and delineate what exactly is the source of this. Any other thoughts? We'll send the mic back to Sudarshan.
Yes, the curious to hear from Sud, what kind of endoscopic evaluation was pursued? EGD, colonoscopy, or endoscopic ultrasound? Yeah.
Yeah, okay, just told everything else that we did. But before that, because I've been sitting on this case for a while, I just wanted to share what the markers actually mean so we know what to do going forward. The TTF1 and NAPSIN being negative moves us away from the lung, as Kirtan already mentioned. And the PAX8 and ER being negative moves us away from gynecological, ovarian, or Mullerian tumors. The G883 moves us away from breast, and even some urothelial cancers. And ultimately, the CDX2 and the CK20 combination takes us to the intestine or enteric lineage. And so that's what was done next. GI was consulted. And an MRCP was done, and there was no pancreatobiliary abnormality. And in fact, they just saw the persistent mass-like consolidation in the right, middle, and lower lobes that had improved from the debulking procedure. And they also saw like a new acute, subacute, severe T8 compression fracture. And a CT spine was done, which confirmed this T8 compression fracture and also revealed some bilateral subacute posterior fractures as well. And they did see multifocal bilateral pulmonary nodules. And there was a lot of back and forth as to whether to do EGD or not because this patient was not consentable. But I think psych was brought on board and decided that she was amenable to get consent from only for the procedure. And so an EGD was done. An EGD showed a gastric lesion near the pylorus with a central depression, which was biopsied. This was suspicious for a pancreatic breast mass. And a colonoscopy was done, which showed a prolapsed rectum and internal hemorrhoids, but no polyps or visible metastatic lesions. And at this point, they actually did not suspect a GI primary. And so they repeated the CT abdomen and pelvis, which showed an interval increase in the bilateral pulmonary nodules and the bulky right hilar posterior mediastinal mass. They also saw a 7.2 centimeter partially calcified multilobulated mass along the superior bladder in the region of the urachal remnant, likely neoplastic and potentially representing a urachal mucinous adenocarcinoma. with primary ovarian neoplasm and metastasis from another site remaining in the differential. And an MRI brain was also done, which showed depleted marrow signal throughout the calvarium. Yeah, I'll stop here.
So yeah, I did. What was the final biopsy? You said mucinous malignancy, right? Adenocarcinoma, was it?
Potentially representing a urachal mucinous adenocarcinoma.
Urachal. Okay, wow. Very interesting. I didn't think it would be from the urachal region there, but it's surprising to see so many metastatic lesions, the pulmonary nodules, the hilar mediastinal masses is like pretty widespread. But this biopsy definitely is an interesting it yields an interesting condition there. At this point, what do you think, Kirtan? I think that pretty much gives the diagnosis.
This
Yeah,
was
no,
not
go
a
ahead.
biopsy. This was a repeat CT,
Oh.
abdomen and pelvis, and we don't have a biopsy done.
Oh, you don't have a biopsy. Okay, sorry.
No, they just think that it's likely to be
Oh.
this from just the imaging.
Giving a suggestion. Sorry, I misheard. Yeah. Okay. So I guess, with such widespread now I know where to start from, but so we don't have confirmed like malignancy or the histopathology. So now we need to go get the histopathology. And which site would be amenable to an easy, maybe the hilar mediastinal mass? You could do a transbronchial needle aspiration. The hilum is easily accessible by pulmonary. The pulmonary nodules, you have to do a transthoracic needle biopsy, but you may face the potential risk for pneumothorax. And then the superior bladder mass could be accessible by interventional radiology. So you kind of have to weigh pros and cons, which one would be easily accessible. I think the hilar mediastinal mass, if there's no respiratory issues, you could easily do a transbronchial needle aspiration at that station. And this is on the right side. So you would do a bronchoscopy, get down to the hilar region, and then poke what we call a wang. There's a retractable transbronchial needle developed by Dr. Kopen Wang. Actually, he used to be at Hopkins. I know him. And that needle is used for any transbronchial needle biopsies. So it's made it very easy to do these biopsies, which we used to have to do maybe open thoracostomy and or VATS to do these biopsies. But I would also get interventional radiology to take a look at this superior bladder mass and see if that could be also biopsied from outside. Any thoughts, Kirtan? Definitely the biopsy, but which station or which area to biopsy is important.
I know, right? That is very challenging and tricky. And this is the part about oncology, which sometimes is like very hard to grasp, is that like you can do your staining, but even staining sometimes is not definitive. And especially when you have multiple sites, it's hard to know that are you sure you have just one tumor and you don't have two tumors? Because sometimes people are very unfortunate and they can have synchronous tumor, which means that like 5 lesions are from, let's say, GI tract, the other 4 lesions are from gynecologic tract, right? So how to make sense of like this whole pathologic process, right? And sometimes what helps in this process is, so regarding the site of biopsy, like I agree what Dr. Singh said, that maybe you can biopsy that lung mass and also this gastric pyloric depression which was present, like maybe they can do the staining on that and see if it is similar to the endobronchial biopsy which they did, right? Urachus site also they can biopsy, but it's like a little bit challenging because it's very close to the bladder. And one final point I would make is that when you're not able to make progress by the staining, you can make progress by the proteomics or the molecular signatures. And this is very well described in hematological world, right? That oftentimes you will find if there is evidence of, let's say, PIK3CA pathway activation, if there is evidence of RAS, RAF, mTOR pathway activation, right? So sometimes if you like staining is equivocal, you can see that what is the molecular signature which is coming from the tumors, and you can stain for these individual molecular pathways. And that's how you can make an inference as to what is the best site of origin. And after all, why are we doing all this exercise, right? It's not just for fun, right? To guess that is it ovarian, is it gastroenterology? We are doing it so that we can guide our chemotherapy, right? Like chemotherapeutic regimens are directed based on the best estimate of what this cancer is, what molecular pathway aberration it might have, right? Otherwise, like it's not like pick any cancer which you think this is most likely, right? It's like it's not that kind of game, but it's more kind of like analytical reasoning that how we are going to best help this patient, right? So yeah, very peculiar, Sud. You have us at the edge of our seat, and looking forward to learn from you. How did you summarize all of this?
So between the findings on CT, uh, the urachal mass, the pulmonary nodules, the mediastinal mass, the osseous mets, and the calvarial involvement, we ultimately concluded that this was a case of a widely metastatic mucinous slash signet ring cell adenocarcinoma of uncertain primary, with the urachal remnant being the leading candidate for the primary tumor site, alongside potential GI, pancreatobiliary, and lung origin still under consideration. So we are actually waiting for the next gen sequencing profiling that for the results to come back. While we did consider doing a cystoscopy with a direct biopsy of the bladder, like urachal mass, this patient was really not in any of the goals of care discussion, and she didn't have family. So I think we just moved to symptom management and sort of tried to keep her comfortable. And I think she's now undergoing palliative radiation and following with oncology. I think oncology has decided to go ahead with the FOLFOX regimen, but they are considering other things. And just as a side note, I think a urachal adenocarcinoma is genomically closer to a colorectal cancer, which is why all of this happened. Closer to colorectal than bladder cancer, which is why this extensive workup happened. And also I think that something that we did was actually just really follow the guidelines for the most part. It was, and if you guys just, if you have the time, just take a look at like NCCN occult primary algorithms for adenocarcinoma, and it's really a presentation based or directed approach where you just kind of go where the symptoms and signs take you, and that's kind of what we did while the workup was very extensive, and we've even had to cut it short a little bit because of decision making capacity. I think it's good learning to yeah, just like follow the guidelines. It doesn't always work, but that's the best we can do.
Absolutely wonderful case, Sudarshan. I know we got into very particulars, sort of overlapping the oncology world, but for a lot of the early learners, just having the complaint, right-sided chest pain, and then doing your due diligence, making a differential, thinking of just this journey here is really important. Getting into then the really particulars about the malignancy and so on. We usually, like, I don't have a lot of that knowledge, but we do get on our oncology friends, pathology friends to help us with making that diagnosis. But I think for the early learners, very important to go through the complaints and acquire the data and refine and come up with your diagnosis. That way we can make this diagnosis in a timely manner. And if it is early malignancy, we can get the patient to chemotherapy like Kirtan has suggested. Time is important with such patients. Kirtan, any reflections with this case? Absolutely wonderful case, wonderful presentation, Sudarshan.
Yeah, no, like I was just going to say blown away by the meticulousness of Sud, right? That like he even taught us in the end that although it was kind of unknown primary, like embryologically speaking, it was thought to be close to the colorectal origin given the urachal. So thank you so much for that teaching, Sud, and giving us extensive data. Hope to learn from your next case as well. A special thanks to Aaron for scribing efficiently. And now we'll pass the mic to Varsha for taking us home with teaching.
Thank you so much, Sudarshan, for sharing this wonderful case with us. We learned a lot today, but I'm just gonna summarize some of the diagnostic approaches that we learned. So when we see a patient with chest pain, the first priority is to always rule out any coronary artery disease or acute coronary syndrome. And we saw that the anatomical involvement includes anterior contents of the thorax and the posterior contents. And the anterior contents are typically the coronary arteries, aorta, pulmonary vessels, pleura, pericardium. and the posterior contents are typically all the posterior mediastinal structures. And as we know, ACS typically, the classical presentation is a left-sided chest pain with the left shoulder, neck, and jaw pain. However, right-sided chest pain is an atypical presentation, more common in females. Right-sided abdominal pain is also an atypical form of ACS. So other anatomical structures in right-sided abdominal pain that we could consider are the hepatobiliary system, the hepatic flexures of the bowel, pancreas, part of the stomach, and even any right-sided lung pathologies, as in our patient who ended up having pleural effusion, etc. And
Aisha for a moment because of the network. Well, friends, like just to be vigilant of the time frame for everyone, like you can see like how excellent the whiteboard has been organized, but I will just highlight the Varsha's key teaching point. So then Varsha has wrote down on the teaching point section that how pleural effusion, how we make sense of that. Actually, versus sensibility to think about the vascular causes and think about certain unique infections, think about neoplastic causes. And if it's neoplastic, the key aspect is it coming from the thorax or is it coming from somewhere else, right? And how do you make progress? You get the imaging, right? And we got the imaging, and then Varsha has jotted down some key teaching points about like that what are the chances of this being ovarian primary or not. And as we said, that the pattern of spread is not making sense. And then we found mucinous, and then in mucinous we figure out is it coming from gynecologic cause or is it coming from colorectal cause. And then finally, as Sudarshan highlighted, that the tumor markers can guide you and help you, but then sometimes even that is not enough, and then you go by the NCCN guidelines, and then you make sense of what this could be. So yeah, that's it. That's the wrap up. Thank you so much to Sudarshan, Aaron, and Varsha, and thank you to everyone for joining. See you next time, friends.